Okay. All right. So we are going to be doing clinical bacteriology today. Okay. Hopefully everyone can see the screen. All right. Okay, so we're going to be starting with gram positives. So if something is gram positive, it is purple or blue. Okay. It is purple or blue, and gram positives are split into bacilli, cocci, and branching filaments. Bacilli uh, can either be aerobic or anaerobic. Aerobic ones, it's Listeria, Bacillus, Corynebacterium. Anaerobic bacilli would be Clostridium cultibacterium, formerly known as Propionibacterium. So, all you need to know about that is that the cultibacterium causes acne, and and the aerobic, aerobic bacilli needs oxygen, and anaerobic does not need oxygen to live. Um, so, and then for the cocci, um, the for cocci it's split into um, streptococcus and staphylococcus, and in streptococcus you have streptococcus is always going to be in chains, and you have hemolysis. Three types of hemolysis. You have alpha, beta, and gamma hemolysis. Okay, so what alpha hemolysis means is that there is a partial hemolysis. Um, so some cells are dead, some are alive. The dead cells stain green. So here the dead cells will stain green. And if you go down further, um, it tells you which one is optogene sensitive and which one is biosoluble. So optogene is an antibiotic, and and it's saying that Verdin streptococci is optogene um, is optogene resistant. Is optogene resistant. Mm, is optogene resistant. Verdin streptococci has no capsule. Um, so optogene does not work on Verdin's streptococci. Okay, and let's see. And it is also bile insoluble. So Verdin's streptococci does not um, does not get dissolved in bile. Okay, now optogene. Um, remember we said it was an antibiotic. So if you go to Streptococcus pneumonia, we know that it is optogene sensitive. So it will get destroyed by optogene. Streptococcus will get destroyed by optogene, and Streptococcus is also biosoluble. Okay, it is also biosoluble. Let's see. Okay, and Viridin streptococci has no capsule. Strep pneumonia is encapsulated. Okay, so now we're done with alpha hemolysis. Now we're going to go to beta hemolysis. This is complete hemolysis. So here you're going to have everything around the bacteria will turn yellow. So everything around this bacteria will be yellow. And here again, bacitracin is an antibiotic, and we also have PYR status. I just call it pyre status, um, and the red stands for that it is resistant to said bacteria or test, and positive means that it is sensitive to said test or bacteria or antibiotic. I mean, okay, so here we have beta hemolysis and uh, group B strep. Group B strep. It's the one for babies. Group B, which is Streptococcus agalactiae, is um, resistant. It is resistant to bacitracin. Group B strep is resistant to bacitracin, and it is also resistant to. Well, no, Group B strep is resistant to bacitracin, and pyre status will be negative. I just remember they're both negative, so bacitracin and pyre status are both negative in Group B strep. That's how I remember it. But whatever works for you. Okay, so let's see, beta hemolysis, and now we go into Group A strep. Group A strep pyogens. So that is Streptococcus pyogens. It is bacitracin sensitive, so it will be destroyed by bacitracin, and its pyre status positive. So pyre status will be positive here. Now remember, the exam likes to come after nitty-gritty details like pyre status, positive, negative. So you want to remember these fine details. That's why I am emphasizing on these details. If you don't like it, you can click off the screen. No problem. Now, however, this is how I study, and I'm just putting it out there for anyone who else wants to study. Okay, so let's see. Next, alpha, beta, gamma. Gamma hemolysis, there is no hemolysis here. This grows in bile. Yeah, no hemolysis. It will grow in bile. The blood agar plate will just show red, and you in the gamma hemolysis you have two organisms, and now we're going to see if they grow in 6.5 NaCl, and also we're going to check out their pyre status. Now, non-enterococcus Streptococcus bovis, it is resistant. So it is resistant. So it means that non-enterococcus bovis does not grow in 6.5 NaCl, and it also is pyre negative. Yes. And now Enterococcus E. faecium and E. faecialis, these both grow in 6.5 percent NaCl, and it is pyre positive. Okay, now we're done with the hemolysis. All right, now next, remember how we said cocci? Let's see. Remember how we said cocci? We're gonna. It is one of the three categories of gram-positive gram-positive bacteria, and we go down and we see catalase, and we see if it's catalase negative or catalase positive. Streptococcus is always going to be catalase negative, and under Streptococcus, that's the only time we're talking about alpha, beta, gamma hemolysis. Now next, now we did the catalase negative. Now we're going to go over to catalase positive, and this is Staphylococcus. It looks like grapes. It's always going to be. It's referred as clusters, so it looks just like millions of little grapes. Now, we have for Staphylococcus, we see if it's split if it's going to be split into either catalase negative or catalase it's either going to be split into coagulase negative or coagulase positive. Um, okay, coagulase negative or coagulase positive. Staphylococcus aureus is coagulase positive. So we can go ahead and say that Staphylococcus aureus is both coagulase positive and catalase positive. Now remember that Staphylococcus aureus is catalase positive and coagulase positive. Okay, now we are going to go on to coagulase negative Staphylococcus. So there is two coagulase negative Staphylococcus, and those two would be Staphylococcus saprophyticus and Staphylococcus epidermidis. Okay, now novobicin is also an antibiotic. We see which one is novobicin sensitive and which one is resistant. Novobicin is sensitive to Staphylococcus epidermidis. So novobicin works on that, and Staphylococcus saprophyticus, novobicin does not work. It is resistant. Remember, if y'all watched Sketchy, you know it's about a very attractive girl, and this helps to remember that she doesn't care about anything. She's not sensitive to anyone or anything because she knows she's pretty. So, and yeah, so remember that novobicin resistance in Staphylococcus saprophyticus, and remember the other guy who was Staphylococcus who had the guy with the indwelling catheters. That is the guy who was represented with Staphylococcus epidermidis, and he felt sensitive about because he didn't feel so attractive. If you all remember the figures, then you all know what I'm talking about. Okay, so now we can go ahead and say this, that Staphylococcus saprophyticus is novobicin resistant and catalase positive and coagulase negative and urease positive. And remember, Staphylococcus saprophyticus is seen in young sexually active girls, causes UTI. Now, and then Staphylococcus epidermidis is catalase positive, coagulase negative, urease positive, novobicin positive. And this is the bacteria that infects the prosthetic heart valves and IV catheters by producing biofilm. Now, and we had already said that Staphylococcus aureus was catalase positive and coagulase positive. Okay, now we said Staphylococcus saprophyticus and Staphylococcus epidermidis are both urease positive. Urease positive. Urease positive means bacteria breaks down urea to make ammonia. So that's what that means. And if something makes ammonia, that makes the environment more basic. That makes it more alkaline. So we'll get into that when we go into physio. But yeah, so that is the let's see, that is the algorithm for gram positives. Let's see. We have one other thing today. Alright, so we have branching filaments up here. So that is the third category under gram positives. We have aerobic and anaerobic. So aerobic, we know that it uses oxygen, and the branching filament here that we have is nocardia, and it's weakly acid fast. It means that nocardia is acid fast because they have mycolic acid in the cell wall. Remember, mycolic acid in the cell wall for nocardia. And anaerobic does not use oxygen. Actinomyces, it is not acid fast because there is no mycolic acid. So not there is no mycolic acid in actinomyces, so it is not acid fast. All right. So remember the acid-fast bacteria. One is Mycobacteria TB and Mycobacterium leprosy. Number 2 is Nocardia. Number 3 is Cryptosporidium oocysts. So the eggs of Cryptosporidium are acid-fast. So just remember those 4 organisms. So the Mycobacteria TB, Mycobacterium leprosy, and Nocardia, and then the Cryptosporidium oocysts. Okay, now we're gonna go on. We're gonna move on. This is just a uh, I guess background. We're gonna get into details. All right, so gram-positive cocci antibiotic tests. We have Staphylococcus. Here, remember how we said there is Staphylococcus saprophyticus and epidermidis. So here, novobicin, we have saprophyticus is resistant. Staphylococcus epidermidis is sensitive to novobicin. Okay, now next streptococcus. We have that. Here we have optochin. Viridans. Viridans is resistant. So if you remember the sketchy video, optochin, his chin was covered. The guy on the whatever animal it was covered. I just remember this as viridans and like mitis and mutants. They both cause some kind of dental caries or some kind of mouth issue. So I just remember that nothing will work. They're going to cause mouth issues anyway. So and optochin, just remember the mouth is near the chin, and whatever drugs you give here is not going to work. So viridans is resistant. So it is resistant to the antibiotic optochin. Okay, now pneumonia, Streptococcus pneumonia is sensitive to optochin. And if you remember the sketchy video, the guy's chin was exposed. So he was exposed, and optochin will work on pneumonia, on Streptococcus pneumonia. Okay, now next we have bacitracin. Group B strep are resistant. Remember, Group B strep are resistant. Group B strep is Streptococcus agalactiae. It is resistant to bacitracin, and it is also pyronegative. Yeah, and then Group A strep, which is pyogens, Streptococcus pyogens, is sensitive. It is sensitive to bacitracin. Yeah, it is sensitive to bacitracin, and it is also pyropositive. Okay, so that's what this means. I just remember this from the algorithm up there. It's easier to remember. I just wrote in the areas of Group B strep, like Group B strep agalactiae and Group A strep. Under Group B strep, I wrote that it is like PYR, and then negative, pyr negative, and also wrote bacitracin negative, and then Group A strep, I just put bacitracin like positive with with a plus, and then pyr positive with a plus. So it just helps you remember. I just think Group B for babies, and babies are a little like resistant to so many things. They're fighters. They get out of, they overcome so much stuff. They, even birthing the baby. It is such a process. It is such a stressful process for the baby. Also, babies are fighters. Group B for babies, and they are resistant to a lot of things. So remember, bacitracin resistant, and also remember PYR resistant. I just remember PYR negative. It's always easier. Nobody's going to ask you what PYR stands for. You just have to know it's PYR negative. Okay, next. Let's see, we're done that. Now we are going to go on to alpha hemolytic bacteria, gram-positive cocci. A partial oxidation of hemoglobin causes greenish or brownish color without clearing around growth on blood agar. Include the following organisms. Let's see. Include the following organisms. We have Streptococcus. Okay, we have Streptococcus pneumonia, and it is catalase negative and optochin sensitive. Yeah, catalase negative and optochin sensitive. Catalase negative. Yeah, remember the Streptococcus is all Streptococcus is going to be catalase negative, and we had said Streptococcus pneumonia is the guy on the horse and his chin is exposed. He is optochin sensitive, and virulent streptococci is always going to be catalase negative because streptococci is always going to be catalase negative, and remember virulence. That's the one that causes the mouth issues. So the chin is always at risk with virulence. So remember, no antibiotic is going to work. That's why they're optochin resistant. Okay, now when we talk about beta hemolytic bacteria, when we talk about alpha or beta hemolytic bacteria, we're always talking about gram-positive cocci. Okay, now keep that in mind. Now next, partial oxidation. What that means is partial oxidation means that you're partially adding oxygen to the hemoglobin. You're partially adding oxygen to hemoglobin, and this causes the hemoglobin to form green. So this is the hemolysis. That's why it looks green on blood agar. Let's see. Yeah. So the green part over here, it's showing dead cells. Okay, it's showing dead cells. All right. All RBCs are not dead. Okay, all RBCs are not dead. So when it's saying it causes greenish or brownish color without clearing, they're saying all RBCs are not dead. Okay. So some live, some don't. That part of this one is a little tricky for me, but basically all you have to know is that Streptococcus pneumonia and virulent streptococci, they're both alpha hemolytic. And they have this is partial hemolysis. Okay. Yeah, beta hemolytic. This is complete hemolysis. So gram-positive cocci, beta hemolytic bacteria affects the gram-positive cocci. We have complete lysis of RBCs. So there will be pale and clear area surrounding the colony on blood agar. Include the following organisms. We have Staphylococcus aureus, which is, remember, it's always going to be catalase and coagulase positive. Now we have Streptococcus pyogenes. Remember, strep is always going to be catalase negative. So catalase negative and bacitracin. This is pyogenes, right? So this is group A. Okay, so group A is going to be, it's always going to be positive, yeah? Bacitracin sensitive. So it is catalase negative and bacitracin sensitive. Streptococcus agalactiae is group B strep. It is catalase negative because it is strep, and it is going to be bacitracin resistant. Remember, group B, babies resistant. Bacitracin resistant, and it is going to be PYR negative. PYR negative. Now, let's see. Yeah, we're done. We're done with that. Now we're gonna go on to Staphylococcus aureus. Let's see. All right, Staphylococcus aureus. Okay, so now Staphylococcus aureus. It is a gram-positive, beta-hemolytic, catalase positive, coagulase positive cocci clusters. So what is that? It is gram-positive, beta-hemolytic, catalase positive, coagulase positive cocci clusters. Okay. So gram-positive means it turns purple on gram stain. Beta-hemolytic means that Staph aureus turns yellow on blood agar. Remember, it turns yellow on blood agar. Okay, so that is Staph aureus. Okay, now we're gonna keep going. Let's see. All right. Okay, so catalase positive. What is catalase? Okay, catalase. So that means here's what catalase positive means. Staph aureus will break down hydrogen peroxide, so Staph aureus is catalase positive. Staph aureus will So Staph aureus will break down hydrogen peroxide, so Staph aureus is catalase positive. Remember, there's a bunch of bacteria that have catalase in them, and the bacteria will break down the hydrogen peroxide so that the host WBCs cannot come and use the hydrogen peroxide to kill the bacteria. We'll get into that, but just know that is the background for catalase. So catalase positive, okay? Staphylococcus is catalase positive. Now, it is also coagulase positive cocci in clusters, as you can see in diagram A over here. Now we can go on to protein A. What is protein A? It is a virulence factor. Okay, now protein A binds to the Fc region of IgG, so that IgG cannot bind to Staph aureus, which prevents phagocytosis. What does that mean? Okay. All right. See this? IgG, immunoglobulin G. So, what is this? So, for IgG, this right here, this is the Fc portion of IgG. So remember, you have to be familiar with the diagram of immunoglobulins. This is the Fc portion right here, and this is where protein A will bind. Protein A will bind to the Fc portion of IgG, and that so that the IgG cannot bind to Staph aureus and so this will prevent the phagocytosis. So this is how Staph aureus gets into your body and thrives in your body. So remember that. So protein A is the virulence factor, binds FcIgG, inhibiting complement activation and phagocytosis. Okay, now commonly it colonizes the nares, ears, axilla, and groin. Causes inflammatory disease, skin infections, organ abscesses, pneumonia, often after influenza virus infection, endocarditis, septic arthritis, and osteomyelitis. Now, there's something you have to know here. Staph aureus is in the synovial fluid, and Staph aureus is the most common cause of septic arthritis. Okay? All right. Toxin-mediated disease, toxic shock syndrome, TSST1. So Staph aureus causes toxic shock syndrome, scalded skin syndrome. Scalded skin syndrome. It also causes rapid onset food poisoning. Now, there's a few things you have to know here. Staph aureus can produce exotoxin. Can produce. One second. Staph aureus. Yeah, it can produce superantigen, it can produce superantigen, and the superantigen here is TSST1. Okay, and that's what causes toxic shock syndrome. Now, Staph aureus can also cause exfoliative toxin, which causes scalded skin syndrome. And it can also, when I say it, I mean Staphylococcus aureus, can also cause food poisoning because it does this through enterotoxins. So there is like a few things that Staph aureus produces, and they result in different conditions. Which toxic shock syndrome, scalded skin syndrome, rapid onset food poisoning. Yeah, Staph aureus secretes TSST1, exfoliative toxin, and enterotoxins. Yeah. All right. So next, MRSA. Okay. MRSA, methicillin-resistant Staphylococcus aureus. It is an important cause of serious nosocomial and community-acquired infections. Resistance is due to altered penicillin binding protein, MECA gene from Staphylococcus chromosomal cassette involved in penicillin resistance. Alright, so vancomycin. Alright, so you treat MRSA with vancomycin. You treat MRSA with vancomycin, and remember how we said it's an important cause of serious nosocomial and community-acquired infections due to the altered penicillin binding protein, MECA gene from Staphylococcus chromosomal cassette involved in penicillin resistance. Okay, now do you know where you find penicillin binding protein? Do you know where in the cell you find that penicillin binding protein? Let me show you. Penicillin binding protein, in case they want to ask. Penicillin binding proteins would be, alright, so penicillin binding protein, so this is gram-negative and gram-positive bacteria. So let me show you BCP, penicillin binding proteins. This penicillin binding protein is found in the cytoplasmic membrane. It's found in the cytoplasmic membrane. Don't forget, right here. Cytoplasmic membrane, which is also known as cell membrane. We can come back to basic microbiology later, but I just wanted to quickly just point that out. Okay. Okay. Let's see. And then next we have, oh, by the way, methicillin sensitive Staphylococcus aureus, you give nafcillin to treat them. So methicillin resistant Staph aureus, you give vancomycin, and if the Staph aureus is sensitive to methicillin sensitive Staph aureus, you give nafcillin to treat it. Okay, and then vancomycin for MRSA, and nafcillin for methicillin sensitive Staph aureus. Okay, next we have TSST1 is a superantigen that binds to MHC2 and T cell receptor, resulting in polyclonal T cell activation and cytokine release. Okay, so what this means is that superantigens can overactivate T cells without even needing the APC cells. So superantigens can directly activate T cells by binding to T cell receptor. Yeah, so superantigens can directly activate T cells by binding to the T cell receptor, but superantigens can still bind to MHC2 and then activate T cells. Okay, activate T cells. Can overactivate T cells by without even needing the APC cells. So superantigens can directly activate T cells by binding to T cells. Okay. By binding to T cell receptor, but superantigens can still bind to MHC2 and then activate T cells. But superantigens can still bind to MHC2 and still activate T cells. Okay. Okay. Now, so TSST1 is a superantigen that binds to MHC2 and T cell receptor that binds to MHC2 and the T cell receptor results in polyclonal T cell activation cytokine release. And polyclonal means lots of different kinds of T cells are activated. Not even needing the APC cells. We activate T cell binding to T cell. T cell will bind to the T cells. Okay, so Staphylococcus toxic shock syndrome. You see the patient will have fever, vomiting, rash, desquamation, shock, and organ failure. TSS toxic shock syndrome results in increased AST, increased ALT, increased bilirubin, associated with prolonged use of vaginal tampons or nasal packing. Okay, compare with Streptococcus pyogenes. TSS, a toxic shock-like syndrome associated with painful skin infection. So strep pyogenes produce something similar. It's a toxic shock-like syndrome, and you get erysipelas, impetigo, necrotizing fasciitis. So what causes necrotizing fasciitis? It is caused by Streptococcus pyogenes, and that is a medical emergency. So it's toxic shock syndrome, but the necrotizing fasciitis, once you see the picture, you'll never forget it. So, in fact, maybe I'll just show you. Necrotizing fasciitis. Oops. Necrotizing fasciitis. Oh my goodness. So this is what this is, and it'll just keep going until you surgically amputate. Okay. We're gotta go back. Okay, let's see. So, Staph aureus food poisoning is due to ingestion of preformed toxin, and this is the enterotoxin. It gives you non-bloody diarrhea. There's a short incubation period, about 2 to 6 hours, followed by non-bloody diarrhea. And emesis, enterotoxin is heat stable, so cooking will not kill the Staphylococcus aureus here. So Staph aureus makes coagulase and toxins, forms fibrin clot around itself, and this is how you get abscess. So Staph aureus makes coagulase, which clots blood around the infection, so the infection can be contained in the absence. This is good for Staph aureus. So that's how they thrive in the body. So remember, Staph aureus makes coagulase. That's why it's coagulase positive. So it clots the blood. So it forms a fibrin clot around itself, and that's what causes the abscess. Okay. All right. Now we're going to move on to Staphylococcus epidermidis. Now, we have gram-positive. We have gram-positive, catalase positive, coagulase negative, urease positive, cocci in clusters. Yeah. Novobiocin sensitive does not ferment mannitol versus Staphylococcus aureus, which does ferment mannitol. Mannitol is a sugar, and Staph epidermidis does not use mannitol like Staph aureus can. Okay. Here, the Staphylococcus epidermidis is a normal flora of the skin. It contaminates blood cultures. So when the skin is penetrated with a catheter, the Staph epidermidis goes inside. Infects the prosthetic devices like hip implant, heart valve, and IV catheters by producing adherent biofilms. So this biofilm protects the Staph epidermidis from the antibiotics and immune cells. Now, Staphylococcus epidermidis is the most common cause of endocarditis. It is the most common cause of endocarditis. It is the most common cause of endocarditis affecting artificially implanted heart valves. Okay, remember that. You treat this with vancomycin. Okay. Now, Staph aureus is coagulase positive, Staph epidermidis and Staph saprophyticus are both coagulase negative. So there is no blood clotting that's happening in Staphylococcus epidermidis or Staphylococcus saprophyticus. The blood clotting is only happening in Staphylococcus aureus. Okay. Let's see. Okay. Now we're going to move on. We're moving on to Staphylococcus saprophyticus. It is gram-positive, catalase positive, coagulase negative, urease positive, cocci in clusters, novobiocin resistant. This is a normal flora of female genital tract and perineum. It is the second most common cause of uncomplicated UTIs in young women. The most common is E. coli. Now, that is all you have to know about that. Just remember that the details, novobiocin resistant, it is coagulase negative, and it causes UTIs in young women, young girls, yeah. So that's there. Now, Streptococcus pneumonia, we have that it's gram-positive, it's alpha hemolytic. Remember that it's partial hemolysis. It's lancet-shaped diplococci. You can see right here what that means. Strep pneumo, making sure another better picture. Strep pneumo. Streptococcus pneumonia. So this is what that means. Gram strain diplococci. So it comes with like two balls next to each other, diplococci. Yeah, so that's what that means. Okay. Diplococci. Now, okay. So, and it is encapsulated. It produces IgA protease. What you ask what IgA protease is? IgA protease is something that breaks IgA down. So IgA protease is something that breaks IgA down. IgA is something that's naturally in our body. IgA helps us fight infections. It doesn't. IgA, helps us. Helps us it helps so the bacteria does not stick to our gut lining, so that's why certain bacteria cannot stick. And but here what happens is streptococcus pneumonia, the IgA protease is something that breaks down protein, comes and breaks down IgA down, and if our protective mechanism is destroyed, there's nothing that can there's nothing to protect us, so obviously we get sick. Now next we have Optochin. Optochin sensitive. Optochin sensitive. Remember, his chin is jutting out from a sketchy, and it is bile soluble. So yeah, it dissolves in bile. Most common cause is most commonly causes what? MOPS, M-O-P-S, meningitis, otitis media in kids, and then pneumonia and sinusitis. Remember MOPS. Now, pneumococcus is associated with rusty sputum. Sepsis in patients with sickle cell disease and asplenic patients. Okay, so there's something you need to know here because strep pneumo has a capsule. You need a spleen to get rid of it. People who don't have a spleen can easily get streptococcus pneumonia. So basically, what happens is when we have streptococcus pneumonia, Neisseria, Haemophilus influenza, all these will be opsonized. So first, IgG will come and coat them. IgG will come and coat them, and then it will take it and then it's taken to the spleen to be mashed up and eaten. But then if somebody doesn't have a spleen, there is no opsonization. There is no eating of this, eating the bacteria because there's no spleen. So, so people without a spleen are very prone to streptococcus pneumonia, as well as Neisseria, as well as Haemophilus influenza. So keep that in mind. And no virulence without a capsule. So basically, the streptococcus needs its capsule to infect humans. Okay. Next, Verdens group Streptococcus. Yeah. So here, this is gram-positive alpha hemolytic cocci. Gram-positive alpha hemolytic cocci. This is optochin resistant and bile insoluble. So Verdens group Streptococci does not get dissolved in bile. This is the normal flora of the oropharynx. Now, there's two things that make up the Verdens group Streptococci. It is Streptococcus mutans and Streptococcus mitis, and they both cause dental caries. Remember, we said these two like to attack the chin, so nothing will work. Optochin won't work in Verdens group strep. So remember this, Streptococcus sanguinis makes dextrins that bind to fibrin platelet aggregates on damaged heart valves, causing subacute bacterial endocarditis. What does that mean? It means that dextrins bind to fibrin platelet clumps on the heart valve. Dextrins are a type of sugar, and this causes subacute bacterial endocarditis, which is also known as infective endocarditis. And subacute means that it slowly develops. It is endocarditis that slowly develops. Okay. Now, Streptococcus sanguinis causes Streptococcus sanguinis is what causes subacute bacterial endocarditis. Verdens group strep lives in the mouth because they are not afraid of the chin. This is just a way to remember that. Sanguines means blood. Think there's a lot of blood on the heart. Causes endocarditis. Next. Streptococcus pyogenes. Group A strep. Group A streptococci. So this one is gram-positive cocci. This is a gram-positive cocci in chains. You can see right here, it's chains. Group A strep causes pyogenic. It causes three things. So pyogenic, this one causes pharyngitis, cellulitis, and pedigo, which is honey crusted lesions around the mouth. I'll just show you what that is. Impetigo. Oh, great. Um, okay, gotta go. So this is what there's a see. It is a color honey crusted. Um, yeah, honey crusted lesions around the mouth. Impetigo is just it's dried pus. That's what it is. Yeah, so pyogenic causes pharyngitis, cellulitis, impetigo, erysipelas. What is erysipelas, you ask? Erysipelas. Erysipelas. This is erysipelas. It looks very painful. All right, so this is all caused by Streptococcus pyogenes. Okay, also known as group A strep. Now, we're gonna move on to the second thing that it causes, toxigenic. Um, Scarlet fever, toxic shock-like syndrome, necrotizing fasciitis. Remember we covered that. Now immunologic, rheumatic fever. So streptococcus causes rheumatic fever, glomerulonephritis. Okay. So what this means is that for rheumatic fever, when we make antibodies against streptococcus pyogenes, these antibodies. So when we get infected with streptococcus pyogenes, our body makes antibodies against them, against the streptococcus pyogenes, and these antibodies can also affect our cells, which can give you autoimmune diseases like rheumatic fever and glomerulonephritis. That is why that is the association between strep pyogenes and rheumatic fever and glomerulonephritis. Okay. All right. So next we have bacitracin sensitive. So yeah, next we have bacitracin sensitive, and um, bacitracin kills strep pyogenes. Um, Also, bacitracin sensitive. It is beta hemolytic. It is PYR positive. And then the hyaluronic acid capsule, and M protein inhibit phagocytosis. Okay, so the hyaluronic acid capsule and M protein stops the phagocytosis. Yeah, stops phagocytosis. Antibodies to M protein enhance host defenses against Streptococcus pyogenes, but can give rise to rheumatic fever. Okay, so yeah, it can give rise to rheumatic fever. So yeah, antibodies to M protein enhance host defense against strep pyogenes, but can give rise to rheumatic fever. Okay, here we have ASO titer or anti-DNase B antibodies indicate recent Streptococcus pyogenes infection. So DNase B is an enzyme found in strep pyogenes. So we make antibodies against this enzyme to fight Streptococcus pyogenes. So we can diagnose a recent Streptococcus pyogenes infection with anti-DNase B antibody. Okay, so let's see. And this M protein, it's made by our body. Humans make M protein that will protect against Streptococcus pyogenes, but can unfortunately give you rheumatic fever. Okay, so for rheumatic fever, um, you get ASO antibodies or DNase B antibodies, and you can also have antibodies against M protein. Our own cells. Oh yeah, so I was just reading, making sure I understood what I was teaching you guys. So the thing is, um, yes, feel free to fast forward to the next point, okay? And you'll just use that as your break time or reading time. Okay, so Pyogenes pharyngitis can result in rheumatic fever and glomerulonephritis. The strains causing impetigo can induce glomerulonephritis. All right, so this is something you gotta know. So infection of Streptococcus pyogenes in the pharynx can give you rheumatic heart failure and post-streptococcal glomerulonephritis, but infection of the skin from Streptococcus pyogenes can only give you post-streptococcal glomerulonephritis and never rheumatic heart failure. So, um, if you got skin infection from Streptococcus pyogenes, it's only gonna give you post-streptococcal uh, post-streptococcal glomerulonephritis. But if you got pharyngitis from Streptococcus pyogenes, you can get either rheumatic fever or glomerulonephritis. So that's just the way you gotta remember. Okay, that's something you gotta remember. And also, Streptococcus pyogenes can also cause scarlet fever, which is blanching of the skin. You get sandpaper-like body, You get sandpaper like body rash, strawberry tongue, and circumoral pallor in the setting of Group A, Streptococcus pharyngitis. Um, and this is caused by erythrogenic toxin. So in erythrogenic toxin, um, erythro means red. Red means scarlet fever, which means erythrogenic toxin gives you all symptoms of scarlet fever. So, um, let's see, which antibodies do you see in rheumatic fever? You see ASO antibodies, and you see anti-DNase B antibodies. Um, and then you also see antibodies to M protein. And remember why this was? It's because, yeah, M protein and the hyaluronic capsule are ways that um, the Streptococcus pyogenes, um, it's a virulence factor for Streptococcus pyogenes. M protein is on the Streptococcus pyogenes, and that's how it invades the body. Um, so on a molecular level, the M proteins are just like proteins found in the heart. Um, So on a molecular level, M proteins are mimicking the structure of heart proteins. So after group A strep, which is streptococcal pyogenes, um, invades, our body will make antibodies against the M protein, and these antibodies will also bind to the heart proteins, um, giving you acute rheumatic fever. This is why you get acute rheumatic fever after a streptococcus pyogenes infection. Okay, that's that. So, what do you see? Antibodies against M protein. You also see ASO antibodies, and you see anti-DNase B antibodies. All right, now that's done. All right. So let's see. All right, so we're gonna do up to anthrax, up to Clostridia, and then we'll end this for today. Then we'll go do the rest tomorrow. Okay. Let's see. Okay, this is group B strep. So, what this is that gram-positive cocci. It is bacitracin resistant. It is beta hemolytic. It is beta hemolytic. Group beta hemolytic means that it lyses RBCs. Okay, now Streptococcus acalactia is something. It is a bacteria that colonizes the vagina. It causes pneumonia, meningitis, and sepsis, mainly in babies. Produces camp factor. Now, this is not cyclic AMP. Okay, this is like the name of the man or woman who found this test. So just have to know that a group B strep, it causes camp factor, um, which enlarges the area hemolysis formed by Staphylococcus. Sorry, Yeah, yeah, it enlarges the area of hemolysis formed by Staphylococcus aureus. Um, all right, it's a hyper test positive, PYR negative. It is groupie strep is seen in pregnant women at 35 to 37 weeks of gestation with rectal and vaginal swab. So you had to screen them at 35 to 37 weeks to check for this. So you screen all pregnant women at 35 to 37 weeks, and if the mom to see if the mom is positive, and then you give penicillin or ampicillin before the baby is born to prevent meningitis, sepsis, or pneumonia. So what I understood from this is that patients with a positive culture receive intrapartum penicillin, ampicillin prophylaxis. So that means when, like during birth, like actually when the baby's being born, you give penicillin or ampicillin. Yeah. So that is what that is. It is so the take home point for this is that it has camp. Yeah, the Streptococcus dacalactiae has camp. Um, it is hepatitis test positive. It is PYR negative, and you screen all pregnant ladies at 35 to 37 weeks, so the child does not get meningitis, sepsis, or pneumonia. Next, Streptococcus bovis. Um, this is something. This is a bacteria that lives in the colon, but if there's colon cancer, the Streptococcus bovis can leak into the blood, causing bacteremia and subacute endocarditis. So it is the Streptococcus bovis is gram-positive, it colonizes the gut. Streptococcus galolyticus can cause bacteremia and subacute endocarditis, and is also associated with colon cancer. So it just this Streptococcus galolyticus is a subtype of Streptococcus bovis, and the only thing you have to know is that it causes colon cancer. Um, yep, that's all I know. All right, and it can cause bacteremia and subacute endocarditis, but the main thing is colon cancer. All right, Enterococcus. Enterococcus is gram-positive cocci. Enterococcus is there's two subtypes: Enterococcus faecalis and Enterococcus uh, Fecian are normal colonic flora that are penicillin G resistant and cause UTI and a biliary tract infection and subacute endocarditis following GI or GU procedures. Um, this enterococcus is catalase negative. It is PYR positive, and there is variable hemolysis. Okay, so GU procedures like after colonoscopy, um, let's see, VRE, vancomycin-resistant enterococci, are an important cause of nosocomial infection. So what you have to understand is some enterococci in the hospital can become vancomycin resistant, and these bacteria become hard to kill, which is why you get hospital-acquired infections. Yeah. So eventually, a lot of these procedures are done in the hospital, like colonoscopy, GIG procedures, and then you keep giving vancomycin, it becomes resistant because bacteria are smart, and there's nothing you can do, it becomes resistant. Now, Enterococci are more resilient than Streptococcus and can grow in 6.5 NaCl bile. Okay. So they can grow in bile, so enterococcus can give you biliary tract infections. Okay, next, Bacillus anthrax. So Bacillus anthrax is gram-positive. It is a gram-positive spore-forming rod that produces anthrax toxin, which is an exotoxin consisting of protective antigen, lethal factor, and edema factor. It has a polypeptide capsule made of poly-D-glutamate. So the polypeptide capsule of anthrax is made is made up of polydglutamate. Colonies show a halo of projections on the petri dish, sometimes referred to as Medusa head appearance. So it looks like Medusa's head. All right, in the petri dish. Yeah. Now, the thing with Bacillus anthrax is that the lethal factor and edema factor both have to be present to prevent the symptoms. Now, cutaneous anthrax, which is right here, skin anthrax. So it is a painless papule surrounded by vesicles. This leads to an ulcer with black eschar. It is a painless and it's painless and it's necrotic. It is uncommon. It can uncommonly progress to bacteremia and death. But this is not the dangerous one. It's unfortunate, but it's not dangerous. So the one that is dangerous is pulmonary anthrax right here. This one. So inhalation of spores, most commonly from contaminated animals or animal products, through although also a potential bioweapon, it can cause flu-like symptoms that rapidly progress to fever, pulmonary hemorrhage, mediastinitis. So in chest X-ray, you see a widened mediastinum, and shock, also called Wolfsrotter's disease. So, anthrax bacilli spores are on infected wool from sheep, and these spores can be inhaled, which gives us growth of anthrax bacilli in the lungs, which gives us pulmonary anthrax, and this is fatal. This that's fatal. All right, sheep are cute, but infected sheep can kill you. All right, now we have Bacillus cereus. Yeah. Okay. Um, okay. Bacillus cereus is a gram-positive rod, causes food poisoning. Spores survive cooking rice, reheated rice syndrome. Okay. Keeping rice warm results in germination of spores and enterotoxin formation. Emetic type causes nausea and vomiting within 1 to 5 hours, caused by cerulide. Remember that, cerulide, a preformed toxin. Diarrhea type causes watery, non-bloody diarrhea and GI pain within 8 to 18 hours. Management is supportive care. Antibiotics are ineffective against the toxins, okay? So remember, this comes from reheated rice. So spores come from environment and latch onto the rice that's stuffed out, and these spores survive being reheated in a microwave, and heat makes spores happy because now spores can release enterotoxin. So this is why you shouldn't leave rice outside. Remember, like one of the those buffets they leave the rice out and they just keep reheating it. It's very possible that you can get Bacillus cereus from buffets because the rice is just left out and reheated over and over again. So remember that. And it is caused by preformed toxin known as cerulide. Antibiotics don't work against the Bacillus cereus because cerulide is already formed, and antibiotics don't work against toxins. Okay. Now we have Clostridia. So we're gonna do Clostridia, and let's see how far we can get. So Clostridia, gram-positive, spore-forming, obligate anaerobic rods. Tetanus toxin and botulinum toxin are proteases that cleave snare proteins involved in neurotransmission. So here, yeah, it is gram-positive, spore-forming, obligate anaerobes. That means that it must be in oxygen-free area, like inside your foot, to survive. Rods. Okay. And tetanus toxin and botulinum toxin are proteases that cleave snare proteins involved in neurotransmission. Okay. Proteases are what? Proteases are things that break down proteins. Snare is what? Snare is something that's found in your body. And this tetanus toxin and the botulism toxin both go in and cleave snare, so that snare can't do its job anymore. So we're going to get into that. So Clostridium tetani produces spasmin, an exotoxin causing tetanus. A tetanus spasmin blocks the release of GABA and glycine from the Renshaw cells in the spinal cord. So, tetanus blocks GABA and glycine from Renshaw cells in the spinal cord. Um, this causes spastic paralysis, trismus, risus sardonicus, which is like that open grin that you see in tetanus. Um, so you're blocking GABA and glycine, yeah? Inhibitory. Okay, so GABA and glycine. GABA is inhibitory, and glycine is glycine inhibitor. One sec. Glycine inhibitory. Glycine is also inhibitory. So you're blocking the inhibitory neurotransmitters in the body, so the body becomes overly excited. That's why you get tetanus. Because if you block an inhibitory, you get excited. You get excited. You get excitatory. So, let's see. Trismus. Yeah. See, these muscles are overly stimulated, and tetanus. Muscles are overly excited. Tetanus. Yeah. See that? Okay. So there it is. Um, let's see. And you see opisthotonus, which is spasms of the spinal extensors, which is archback, which is what we just saw. Um, you can prevent this with the tetanus vaccine. You can prevent this with a tetanus vaccine. You can treat this with a antitoxin, with or without a vaccine booster, um, antibiotics, or diazepam for muscle spasm and wound debridement. So basically, if somebody comes in with a needle up their leg, give the tetanus vaccine. Um, Tetanus vaccine is made from tetanus toxin, and that's you. This is how you prevent the archback. You treat them before it gets that way. Now, after they have all the symptoms, you treat with antitoxin plus or minus vaccine booster. So, if somebody has an archback and lockjaw, you give antitoxin pre-made, which is a pre-made antibodies with a vaccine booster, which is made from tetanus toxin. Okay, remember that. So you give antitoxin with or without a vaccine booster. This is antibodies. Um, to somebody who's actually having tetanus attack. All right. Now diazepam makes the cell more negative, so diazepam calms cell down and stops muscle spasms by increasing chloride frequency. So chloride can come into the cell, making the cell more negative. So chloride will be inside the cell. Goal of benzodiazepine is to increase chloride inside the cell. Yeah, is to increase the chloride in the cell. So diazepam is to calm the muscles, makes the cells more negative, increases chloride frequency, so cell can come into the cell so chloride can come into the cell, making the cell more negative inside the cell. Goal of the benzodiazepine is to increase the chloride inside the cell. All right. So that's that. Tetanus is a tetanic paralysis. Tetanospasmin breaks down snare, so snare cannot release GABA and glycine from the Renshaw cells in the spinal cord, so the patient gets archback and lockjaw. Tetanospasmin causes overexcitation of the muscle. Okay, all right. So now we know that. Now we're going to move on to Clostridium botulism. All right, Clostridium botulism produces heat label toxin that inhibits acetylcholine release at the neurotransmitter junction. So heat label means that it cannot survive in the heat. It will die in the heat. Um, so this produces a heat label toxin that inhibits Clostridium. Sorry, Clostridium botulinum produces a heat label toxin that inhibits acetylcholine release at the neuromuscular junction, causing botulism. In adults, disease is caused by ingestion of a preformed toxin from the food. In babies, ingestion of spores, like in honey, leads to disease, like floppy baby syndrome, treat with human botulism, human immunoglobulin. So you don't give babies honey for up to a year, okay? Don't do it. Um, all right. So Clostridium botulism creates botulism toxin that is an endotoxin, which blocks the breakdown of snare protein. So now snare protein cannot release acetylcholine from NMJ. Creates botulism toxin that is endotoxin which which blocks breakdown snare. Okay, so um, Clostridium botulism creates botulinum toxin that is an endotoxin, which breaks down snare protein. Yeah. Which breaks down snare protein. So now snare protein cannot release acetylcholine from NMJ. So no movement. There is no movement. Acetylcholine is important for the movement of muscles. So there is no movement here. That is the mechanism of action of Clostridium botulism, and adults get it from um, food. All right. So symptoms of botulism: the 4Ds: diplopia, dysarthria, dysphagia, and dyspnea. Diplopia, you start seeing two of things. Dysarthria, you have slurred speech. Dysphagia, you can't swallow. Dyspnea, you can't breathe. Um, Botulism is from bad bottles of food, juice, and honey, causes a descending flaccid paralysis. That means that the feet will be last to be paralyzed, cause a descending paralysis. So basically, your arms go flat first, then your torso, then your legs. So the feet will be last to be paralyzed. Um, okay. Local botulism toxin A, Botox. Injections are used to treat focal dystonia, which is extreme contraction of the muscles, hyperhidrosis, muscle spasms, and cosmetic reduction of facial wrinkles. Hyperhidrosis, you give Botox to correct so that acetylcholine can't make you sweat anymore. Increased acetylcholine makes you sweat normally, so if you block acetylcholine, you can't sweat anymore. So that is how Clostridium helps in hyperhidrosis. Um, it blocks acetylcholine. Okay. Now, what do you think of Clostridium? Okay, so think of Clostridium botulism when lots of people complain about being floppy uh, or seeing two things after having food from a common place. Now we have Clostridium perfringens. Clostridium perfringens is something that produces the alpha toxin. Um, Lec- lecithinase, a phospholipase that can cause myonecrosis, it's also known as gas gangrene. So, gas gangrene, right here, this is gas gangrene, this diagram. Okay, gas gangrene presents a soft tissue crepitus and hemolysis. If heavily spore-contaminated food is cooked but left standing too long at less than 60 degrees Celsius, spores germinate, and this causes vegetative bacteria, and this causes heat label, and this is causes heat label enterotoxin, and this causes food poisoning symptoms in 10 to 12 hours, resolution in 24 hours. Okay, so yeah, Clostridium perfringens. It produces alpha toxin, which is a lecithinase, a phospholipase that can cause myonecrosis, can cause gas gangrene, presents a soft tissue crepitus, and hemolysis. If heavily spore-contaminated food is cooked or left standing too long at less than 60 degrees Celsius, spores germinate, and this causes vegetative bacteria, and this causes heat label enterotoxin, can cause food poisoning symptoms in 10 to 12 hours, resolution 24 hours. Alright, so crepitus, what that means is it's the sound of air bubbles in tissues when you touch the necrosis. Hemolysis is due to RBC cell membrane being broken down because it's made of phospholipids. Alpha toxin breaks down phospholipids by using phospholipase. Alpha toxin breaks down phospholipids. Alpha toxin breaks down phospholipids by using phospholipase. Um, okay, Alpha toxin breaks down phospholipids by using phospholipase. If food is contaminated with spores and cooked but left out too long at less than 60 degrees Celsius, then spores can germinate in this environment. Spores can develop into bacteria, and bacteria that grow from spores are called vegetative bacteria. These bacteria can make toxin, and this heat label enterotoxin can give you diarrhea. Okay. So for gas gangrene, you hear crepitus, which is the sound of air bubbles in tissues when you touch it, when you touch the necrosis. Um, and the hemolysis is due to RBC cell membrane being broken down because it's made out of phospholipids. Now, you need to know that Clostridium perfringens secretes both alpha toxin and enterotoxin. Alpha toxin alpha toxin is dangerous. It causes the gas gangrene. Um, Now, enterotoxin is what causes the diarrhea. Um, that's not dangerous. The main point here is dangerous is the Clostridium perfringens that causes the gas gangrene. Okay, next, Clostridium difficile produces toxins A and B, which damages the enterocytes, so damages your intestines. Both toxins lead to watery diarrhea. Both toxins lead to watery diarrhea, and this causes pseudomembranous colitis, often secondary to antibiotic use, especially clindamycin or ampicillin. Remember clindamycin. Clindamycin is the main culprit in C. diff. It's associated with PPIs. Because if there's no acid to kill off the C. diff, because protein pump inhibitors decrease the HCl in your gut in your stomach. So if there's an acid to kill the C. diff, it makes it worse. Yeah. So remember that PPI, clindamycin, diarrhea. This person has C. diff. Diagnosed by PCR or antigen detection of one or both toxins in the stool. Um, which toxins? Toxins A and B. Complications of the toxic megacolon infection causes dilation of colon and they can rupture, leading to sepsis. Yeah. Okay. So difficile causes of diarrhea. Treatment is oral vancomycin, metronidazole, or metronidazole. Yeah. Treatment is oral vancomycin, metronidazole, or fidaxomine. Treatment is oral vancomycin, metronidazole, or fidaxomicin. For recurrent cases, consider repeating prior regimen or fecal microbiodata transplant. So basically, this is a poop transplant. So patient can get new poop and new normal bacteria along with this, so C. diff doesn't grow anymore. Okay, so recurrent cases consider poop stool transplant. Um, Now, if somebody's actually having, give them oral vancomycin, metronidazole, or fidaxomicin. All right. So, if somebody with C. diff infection, someone with C. diff infection with infected C. diff hands touches food of patient who is getting clindamycin, that patient can get C. diff. People who are on clindamycin are more susceptible to get C. diff. You can't really get C. diff if a C. diff patient touches your food and you eat it. Alright, so if someone with C. diff infection with infected C. diff hand touches food, a patient who is getting clindamycin, that patient can get C. diff. So people who are on clindamycin are more susceptible to get C. diff. You can't really get C. diff if a C. diff patient touches your food and you eat it. Okay. Your hands have to be infected with C. diff. Someone's C. diff infection is infected with C. diff hands touch your food touches food a patient who is getting clindamycin. That patient can get C. diff. Yeah. Well, that person has multiple factors. Of course, they can get C. diff. People who are on clindamycin are more susceptible to get C. diff. You cannot really get C. diff if a C. diff patient touches your food and you eat it, because your HCl will kill it. Yeah. Okay. So, um, all right. So spore is always bacteria. Spore is always bacteria means spores grow into bacteria. Yeah, spores grow into bacteria. The bacteria that grows from spores is known as vegetative bacteria. Where do you see vegetative bacteria? You see that in Clostridium perfringens. Yeah, you see that in Clostridium perfringens. And this is the bacteria that causes, this type of bacteria from perfringens will cause diarrhea. Like non-bloody diarrhea. Alright, enterotoxin is a type of exotoxin. Exotoxin is in both gram-negative and gram-positive bacteria. Endotoxin is only in gram-negative bacteria. Okay, that's just something I don't know. When we will do that, we go through basic microbiology. Enterotoxin is a type of exotoxin. Clostridium perfringens, yeah. Clostridium perfringens, these ones are all, let's see, Clostridium perfringens. Clostridium perfringens. Clostridium. Yeah, Clostridium perfringens is an exotoxin, but it also produces an enterotoxin. Yeah. Okay. So, Clostridium perfringens. Yeah, Clostridium perfringens is an it does produce exotoxin, but it also produces enterotoxin, which is what gives you the diarrhea. So enterotoxin is a type of exotoxin. Exotoxin is in both gram-positive and gram-negative bacteria. Endotoxin is only in gram-negative bacteria. So which one is more dangerous, exotoxin or endotoxin? Okay. Which one? There is one that was more dangerous, and I think it's endotoxin. Endotoxin is more dangerous. Let me just look it up. All right, endotoxin. Um, oh, today's the endotoxin. Crap, it's exotoxin. Exotoxin is much more dangerous. Exotoxin, um, the adverse effects is high. The fatal dose is much worse than endotoxin. All right, so it's exotoxin. Exotoxin is so much more worse. Exotoxin. Think of exit. Yeah, once you have exotoxin, it's like exit, exit stage left. All right, that's it. That's it for today. We are done with that. We are gonna start with Corynebacterium next. All right. Okay. Good night.